Thank you very much for being here, those of you who are in this room, and also all of you that are elsewhere. It's also an honor to get the chance to present for all of you. And the talk of the name of my talk today is how to ensure the best quality of life and how we should always consider optimizing the treatments for our glaucoma patients. So let's see if it moved. So these are my disclosures, and I'm very proud to be collaborating with the industries because that's how we innovate and how we make progress. So the agenda of my talk is, first of all, why do we need to talk about glaucoma? What do glaucoma patients look like? Why do patients with glaucoma lose visual function? And how can we optimize treatment for our patients? And in the end, conclusion and discussion, and I would like to discuss with you and take questions and debate if you like. So why glaucoma? You all know in this room and out there that glaucoma is a quite common disease, and it's one of the leading causes of irreversible blindness. Despite current treatment strategies, we're really lucky in glaucoma. We do have treatments. Lowering the IOP is actually lowering the rate of progression. But despite that, many of our patients are still facing blindness or visual impairment. And it's not only about visual impairment, it's also about how to function in daily life, drive a car, also be socially active, free to integrate with your peers. So in the end, it's not only about visual function, it's about quality of life, which is my talk, which is what my talk is about today. So if we look at the World Glaucoma Association that you all know, the goal of glaucoma care is actually to eliminate glaucoma-related disability worldwide. And I think we can all agree that that's a really important goal. If we then look into the European Glaucoma Society goal, it took us about 4 days to actually articulate this sentence. And what I like about this sentence is not only that we need to care about people at risk or with glaucoma, but we really need to take into considerations their well-being and quality of life. We never need to forget that the definition of glaucoma is a progressive loss of the retinal ganglion cells and their actions. That's what we mainly focus at. But I'm going to talk to you today about what is as important, the quality of life for the patients and their adherence to treatments. So how do our patients look like? Well, we have a group of diverse and inhomogeneous patients or people, and that's due to the multifactorial nature of the disease. We have clinical phenotypes, and just to be very sure that we all agree what we're talking about, a clinical phenotype is when you do not know the reason for that subtype, but you try to look at the patients and then you categorize them into groups that look alike. So we don't really know what we're dealing with, and what I'm going to talk about today is the clinical phenotype named open-angle glaucoma. And within this group, we certainly do not know what we're talking about. It's a multifactorial disease. So why do our patients actually lose sight or visual function? Well, one major challenge is late detection, and I'm sure that that's also the case in India. Late detection is the most high risk of visual impairment in glaucoma. Then we have uncontrolled IOP due to non-adherence. I will definitely touch very much base on that today. And then unfortunately, we also have uncontrolled disease despite good adherence. So those patients that take their medication and still progress. Now, late detection is due to the asymptomatic nature of the disease. So even at advanced stages or at moderate stages, such as in the middle of this picture, you will have a perception of the patients being normal. So if you look at the flowers in the mid picture, they're almost normal, and you wouldn't know that any flowers were disappeared if you didn't know any better. But doing a visual field test will show you that you have advanced glaucoma. But this is one of the main reasons that people with glaucoma are not seeking healthcare. Now, what do we want to, how do we want to proceed with this? How do we want to make it better? Well, we need a better risk profiling. We need to understand how people with the glaucoma or at risk of getting glaucoma, risk of fast progression, how do they look? We want to get to the aim where we can actually decrease the rate of progression so much in the patients with glaucoma that they will have a very good visual function for the rest of their lives. And I'd like to introduce you for one research project that we're doing in Copenhagen, and that's called Project Forever. Project Forever is aiming at being better to risk profile the population. This is a collaborative project between one of the largest optician shop chains in Denmark and University of Copenhagen. So we are recruiting customers from the optician shop around the entire country. There's 100 shops around the country, so we recruit in a demographic very well way. Now, since 3 years, just 3 years, we've recruited 80,000 participants. And that's very important because these patients or participants, not patients, participants, they are most highly normal patients. So we can follow them for years and see who are then going to develop glaucoma. So we want to use Project Forever to identify risk factors for visual impairment and glaucoma in particular. I would like to welcome you also to contact us because we're just opening the database if anybody would be interested for external researchers that might have very important research questions. Now, we are doing machine learning using the very high quality imaging from Project Forever. We have found some few initial associations between differences or changes in the vessels in the retina and IOP. These are just the very beginning. We're also going into deep learning methods if anybody would be interested. And we are now testing available data sets around the world to prepare to go in and use our Forever dataset for this purpose. So you're very welcome to read more about Project Forever and maybe even ask about access and then do some very nice research projects that can help us risk qualify or risk profile our patients. That leads me to the next challenge in glaucoma. That's poor adherence. And that's really something that we should take into consideration because here we actually have a group of patients that have the diagnosis and we can actually make a difference by treating them with IOP lowering treatments. However, many of them are not taking their medications as they should. In the CEGIT study, which is one of the landmark studies in glaucoma, we saw for the first time, or they found for the first time, that non-adherence or low adherence is actually related to a faster rate of progression. This was the first time that was actually evidence-based, but that's important to understand. It does matter with good adherence. So uncontrolled IOP due to non-adherence, why is that? Well, that can be lack of understanding of the treatment and the disease. It can be complex regimes, and it can be due to the fact that we are treating our patients with generic eye drops that might have preservatives or other inactive ingredients that might not benefit the patient. I'm going to take you through these. So lack of understanding. We have a patient group with an asymptomatic disease. They have no symptoms. They are recognized with glaucoma, and then we start treatments, most likely eye drops, and that causes stinging, red eyes, and many side effects, unwanted side effects. So no wonder that they're not going to take these eye drops because they came with no issue, and now they have a lot of challenges. We understand that actually many of our patients are not taking the medications as they should or as recommended. And poor adherence also come with high cost for society, not only for the person that has glaucoma, which is obviously the most important part. We've done a study where we looked into adherence and who is non-adherent. We found two things that are very interesting. We found out that good adherence the first year is actually a predictor of good adherence down the line. So we can here risk profile our patients for good adherent patients and maybe less good adherent patients. We also find some characteristics of the ones that we should notice most, and that was, men, younger patients, and patients with comorbidities. So taking me to the complex regimes, we as physicians really like to make a difference. So we tend to give more eye drops. Okay, the pressure is not fine. There might be some progression. We add another eye drop. But that can actually cause a lot of issues for the patients. If it's a patient that travels a lot, if it's a shift worker, if the cost is an issue, which it very often is, and maybe also due to the tolerance or lack of tolerance in the ocular surface. We need always to have a holistic view of a patient. What is the human being in front of us? What characterizes this person, and how is the daily life of this person? And I know you do so at Aravind Eye Hospital. I learned that, and that's very nice. We also know that comorbidities are really bad for adherence. So if we have a patient with neurodegenerative diseases, arthritis, or anything else that can prevent them from taking their medications as they should, that's also an alarm clock for us to be careful when we prescribe medications. If we look at the eye drops by themselves, there are certain things that we need to take into consideration, because an eye drop is not just an eye drop. And prostaglandin analogs are not just prostaglandin analogs. I'm going to take you through this. So whenever we have an eye drop, we need to consider the active drug, the inactive ingredients, and also preservatives. So let's start with the inactive ingredients. Inactive ingredients are the ones that are in the vehicle on top of the active product. That can be pH regulators like buffers. It can be stabilizing agents that are stabilizing the active drug so that it keeps its activity. It can increase solubility. It can affect the viscosity, which is also important for how long will the active component actually stand on the ocular surface to actually be active. And then there is new debates about phosphates. It can be in the buffer, phosphate buffers. Can that affect cornea? Personally, I think that we should be definitely thinking about phosphates if we have corneal issues. If we look at generics, generics are very commonly used in Denmark, and I just tried to look it up in India, and what I saw was that it's also very common in India, but you have to correct me if I'm wrong. But what is a generic eye drop? Well, we tend to think it's a copy of the original brand name. However, if we look into the regulations, which may be different in India, but I suspect that they're not very strict in India either. So in Europe, you only have to have 20% of the active substance in a generic eye drop. So it can vary 20%, which is quite a lot for efficacy. It has to have the same bioequivalence. That means the same concentration in the blood. But we know when we're using topical medications, the bioequivalence is not that important. Maybe a little bit for beta blockers, but not for the rest. And then it needs to have the same administration form. That means you cannot change an eye drop into a tablet. But that's very, very few requirements. If you look into efficacy or side effects, there are no regulations. So you can actually add whatever you want into the eye drops. And despite that, 75% of eye drops in Denmark are generic products or eye drops. Now, we did a study some years ago, actually quite a few years ago now, but we were asked by the patients, so are these generic eye drops the same? And if you see at the picture here, you would see that these are all generic latanoprost products. So we purchased all the latanoprost products from the pharmacy that were available at that time, and we examined the chemical and physical activities. And independently of what we examined, of course, no efficacy or side effects because this was only the bottles, but the chemical and physical activities all were significantly different from each other and from the original brand name. I just want to state also that the original brand name Salatin, which ran out of patent in 2011, when we examined the pH here, it was 6, whereas the generic variants was 6.7. Then we read the very, very small letters that when it went off patent, it actually changed pH to be able to stand at room temperature. So now not even the original brand name is the original brand name. So that's very confusing, and we actually really have to take that into consideration, in particular if our patients are complaining or describing new symptoms, and we are also obviously if we experience that the IOP is not regulated as it should be. One other thing that we looked into was the bottle design. There are no requirements for the bottle design, and you know also that it can be very hard to get an eye drop out of the bottle. We tested it and saw that the different variants, the different generic variants, had very different bottle designs, and the force to squeeze out 1 and 2 and 3 eye drops are very different. So that's also something to take into consideration. Now we are doing preclinical studies in our laboratory, like you are here at Aravind, and to study the side effects of these different eye drops, we're growing goblet cells. And goblet cells are the conjunctival cells that are producing mucin, which is very important for the inner layer of the tear film. Now, you know the inner layer mucin, then you have the aqueous layer, and then you have the lipid layer on the outside made by the meibomian glands. Now, we're growing the goblet cells, and what we do is we then expose our goblet cells to the different eye drops. So back before 2023, we examined Travatan, the original brand name, with its generic variants. And if you see here, the original variant is preserved with polyquat, whereas the generic eye drops were preserved with benzalkonium chloride, the most used preservative in our eye drops for glaucoma. We know that polyquat is a larger molecule and it's less toxic. So we tried to add it to our goblet cells, and what we saw was, just in brief, that the generics, they were very toxic to the goblet cells, whereas the original brand name was not. With that and many other studies that we did that I don't have the time to discuss today, we went together with the Fight for Sight Denmark and the Danish Glaucoma Society, went to the authorities, and in fact, this is a success story for the patients. In 2023, we actually got them to add a new requirement for introducing generic eye drops. So now it's not legal to subsidize benzalkonium chloride into a generic eye drop where the original does not have it. But I don't know if that's the case in India, and I think that you should be very aware of this because benzalkonium chloride is definitely more toxic than other preservatives. So that takes me to preservatives in general, and a preservatives and benzalkonium chloride, the major preservative used in eye drops, is the same as what we're using when we clean the floors. That's the same that we find in mold removers. If we look it up at Wikipedia, obviously not scientific, but we see that it's a severe eye irritant. And isn't it a paradox that we add that to our eye drops? Well, if you ask me, since it's not important anymore, it's not necessary anymore because we are now having the opportunity to have emballages with filters, so we don't have bacterial growth in our eye drops anymore. So then it becomes really a paradox that we still add it to them. Now, benzalkonium chloride, it's a pro-inflammatory molecule. It kills the cells on the ocular surface, and it destabilizes the tear film, which is essential for comfort of the ocular surface, which is essential for not developing ocular surface disease. And there's been many studies associating benzalkonium chloride with ocular surface disease, and many studies showing that if you pause or stop benzalkonium chloride, your ocular surface will become much better. Now, another paradox. Many of our patients are experiencing ocular surface disease or dry eye disease, call it what you want, and then we start to use artificial tears. However, many of our artificial tears also consist of benzalkonium chloride. That's really, really, really a paradox. So we are doing a study, we're just submitting the study, showing that exploring all the different artificial tears and showing the side effects of benzalkonium chloride in the artificial tears. We've also done a study from the Forever cohort that I just briefly mentioned, where we can see that the third most used artificial tear in Denmark is with benzalkonium chloride, very toxic to the ocular surface. That's published in ACTA. We also did this review in ACTA. You can find both of them in ACTA and read about the different artificial tears. And I'm sure that you have other variants in India, but unfortunately you may also have some with benzalkonium chloride, and I would definitely argue not to use those in people with glaucoma. So then it takes me to the group with disease, progressive disease or progressive glaucoma despite good adherence. That's when we get so sad. We have a patient, it's recognized, the patient is taking its eye drops, her eye drops every time. You can set a clock and they will take it. They're just like they have schemes and they're so adherent. And yet they progress. That's the patients where I don't know what to do, basically. But we know that the major risk factors are age, genetics, and IOP. And we can do something about the IOP, but what about the other risk factors? The only thing we can do as we speak is lower the IOP. That's the only evidence-based treatment for now. You might teach me some from India that I don't know, but as far as I know, that's the only. Now, we also know that that's not the only risk factors. There's a majority of different risk factors, many different risk factors, and some of them are mitochondrial dysfunction. I'll come back to that in the end, inflammation and comorbidities. But that means we're treating a disease where we actually don't know. And if you ask me, every single person has a buffet of different risk factors. Some have more IOP as a risk factor, some have more inflammation or mitochondrial dysfunction. And that again is why we need to risk profile our patients. And I think that in the near future, we'll have polygenic risk scores as well, that where we can actually see more and learn more about these new risk factors, or not new, but these unknown risk factors. So how can we optimize the treatment for our glaucoma patients? That's exactly what my talk is about. Well, we can better stratify treatments. We can focus on the ocular surface. I'm going to talk to you about the ocular surface, and we can consider IOP independent treatments. If we think about stratification to our treatment, we are in that good situation that the availability of preservative-free options is improving. We have new active drugs. We also have implants, and we have SLT or trabecoplasty as a primary treatment option since LIGHT study in 2019 came out. That was a major change in our protocol for how we treat patients. And then there are emerging mix, and I know that you're also doing mix here. If we look at the preservative-free options in Denmark, we just got a new latanoprost product, and we have many generic products now that are preservative-free also. We need to watch out because they are not the same as the original brand name either, so we still need to watch out. But I do think it's good that we got rid of preservatives. Unfortunately, and we are debating a lot in the newspapers, in the press in Denmark, and that some of the good drugs that actually exist are not available in Denmark, such as betaxolol without preservatives. I use betaxolol when I have a timolol allergy, and it's a very good drug. But it used to be available preservative-free in Denmark, but they took it off the market. And I'm like, we're spending so much money on developing new treatment strategies, and then you remove a good working treatment. So we need to debate about that. We need to articulate that's really not good. Alpha-2 agonist in Portugal, they have it preservative-free. In Denmark, no way. And that should not be the case. I understand the difficulty of, developing new drugs, such as long path, but to remove good existing drugs from the patients, that's just not okay. We have new drugs. Rho kinase inhibitors were introduced a little bit more than a year, maybe even 2 years ago now in Denmark. We unfortunately only have it as a combined therapy. That doesn't make sense, right? Rho kinase inhibitors do not come without side effects, and obviously some patients are not tolerating them very much, and then we'll have to see. And they also were introduced with benzalkonium chloride. Hooray! But I know that they are working on removing benzalkonium chloride. Other active drugs are available elsewhere with the nitric oxide, but we don't have them in Denmark. We did a study some years ago where we looked into how does the world look like? Well, there are a lot of clinical studies going on new medical targets, which is very good, and also new surgical approaches. So we're in a good path in glaucoma. I'm very positive for the future. Implants is being introduced and actually is available in the US. This is the bimatoprost implant. We were engaged in the clinical trial. Unfortunately, it's not accessible in Europe as for now. I hope that we'll have it in a few years. I think that it does definitely not go for most of the patients, but there are some patients that would really benefit. And the patients that we had in our clinical trial, they are so sad that they cannot keep on having an implant, because you don't need to use eye drops every day. You spare the ocular surface. Obviously, you're not cured, and that's important to tell the patient, but it is very nice for some patients. We have the SLT, other trabeculoplasty options, but the SLT is widely used, and I understand that here you have the size. We're just getting the size in Denmark, and I'm very thrilled about it. I've used Alex and the Nidec, but I'm looking forward to trying the size as well. There are amazingly few comparative studies on the SLTs. We will try to do it, but I hope that you will also engage in that because you have such a volume. But it's amazing so little we know actually about how they work compared to each other. Surgical procedures, mix, we are doing pressure flow, which is not a mix because it's a bleb forming surgery, but mix is also developing very fast. And I think that there is improving literature showing that it actually is effective. We still need more evidence in this field, but I am very positive about that as well. So why do we need to talk about the ocular surface? That's one of the fields that I'm very concerned about because that's something we can do something about, and it's a low-hanging apple. That means it's not that difficult, right? And we know that many patients in our glaucoma clinic and maybe just in the community, they have so severe ocular surface disease, and we don't always recognize it. So it's very often inadequately treated. So what do I think we should do? Well, I think that we need to evaluate the ocular surface on our glaucoma patients, estimate risk factors, like are there any particular risk factors? What are the symptoms? What are the signs? If we have a very red eye with a lot of punctate staining, be careful. I mean, that patient is not having the best quality of life if we start adding preserved eye drops to the eye. And then reevaluate. If you change treatment or you initiate treatment, reevaluate. In particular, if you change treatment, reevaluate your patients and look at the ocular surface. We really can help our patients. Also, you can consider alternatives to eye drops. SLT, obviously, I use it very often now for first-line treatment. Bimatoprost implant, other implants, maybe if they're available, unfortunately not in Denmark as we speak. And the mix or early glaucoma surgery is also an option. We've been a little hesitating previously, but I think that going down the line, we may use more mix earlier in glaucoma, and I'm very excited about your opinion on that. And only use preservative-free artificial tears. It does not make sense to add preserved artificial tears to a patient with glaucoma where the ocular surface is already suffering. Now, IOP-independent treatments, what is the landscape here? Nicotinamide, I'm sure you've all heard about nicotinamide. It's a really nice story. It was shown to decrease, to rescue the retinal ganglion cells in preclinical models. It's also been shown that glaucoma patients have less nicotinamide in their blood. So everything makes sense to try to treat with nicotinamide. And there are many ongoing clinical trials, at least 6 around the world. And they're using 1.5 grams per day for 6 weeks and then 3 grams afterwards. I've been so excited that I've actually prescribed that to my patients, knowing that it's yet not evidence-based and only based on the preliminary results indicating that nicotinamide will actually improve the inner retinal function in patients with glaucoma compared to placebo. However, recently there has been some cases with a liver injury based on nicotinamide treatment. And actually at the Glaucoma Research Society, we were debating what should the opinion be for the use of nicotinamide in our glaucoma patients. And as I understood, and which I really agree on, is that the threshold for side effects needs to be very low when you don't have evidence. And 3 grams per day is a quite high doses. I really trust, I hope that we will have evidence and then we can prescribe nicotinamide in those doses. But until we have that, I would suggest, and we suggested, and I think agreed upon, you have to correct me if I'm wrong, that no more than 1 gram a day until we get evidence, or even not. But you know, some patients, if you really want to do something, maybe 1 gram a day is not bad. Then we're running a trial. This is first in the world, I think, on GLP-1 receptor agonist. This is a drug for diabetes. This is an anti-inflammatory drug. This is reducing excitotoxic effect of glutamate. This is boosting the mitochondria. It's also used for obesity. So you probably know all about Wegovy. Clinical trials are running in Alzheimer's disease, and the preliminary results are very positive. And based on that, we hypothesized that if it benefits patients with neurodegenerative brain disease, such as Alzheimer's disease, why would it not benefit patients with glaucoma? So we were fortunate after a long time to get funding to run this trial. It's ongoing. It's really not, it's a challenging study, but patients like to be offered semaglutide because it's really difficult to get access to. So we are running this study with 126 patients, 2 arms, placebo or semaglutide. And the primary endpoint is photopic negative response. That means in a retinal function, power calculation based on the nicotinamide study. So we hope, imagine that this drug or these drug, it's a group of drugs, would benefit our glaucoma patients. That would be very nice. So in conclusion, we still don't know much about our population, and we need to have improved risk profiles so that we can intervene timely in those at risk of glaucoma or with glaucoma, but at the same time not focus on those without risk. Every time you have a human being in front of you, I would say have a holistic view, a holistic approach. This is not only about glaucoma, it's also about the quality of life and the well-being of the patients. And here the ocular surface, if you ask me, should be taken into consideration. Remember that generic eye drops are not the same. Remove or even reduce benzalkonium chloride. We did a study I didn't show you where we actually looked at different concentration of benzalkonium chloride, and it's a concentration-dependent toxicity. So it does make sense to just reduce benzalkonium chloride if you have no other options. And in particular, do not use artificial tears with benzalkonium chloride. We are looking into new treatment modalities, and they are currently being investigated. But if we use them, such as nicotinamide, we need to use them wisely because we do not have the evidence yet. Here it comes again. It can cause liver failure or liver toxicity, so we need to be cautious. And then the GLP-1 receptor agonist, that's my new favorite, may benefit glaucoma patients. Let's see, maybe not, but then we'll find out. With this, I'd like to thank you very much